Welcome. I hope you're having a wonderful day. Here's a case about Bob, who has classic symptoms and onset of Parkinson's disease. Let's discuss the drugs in the next several slides and then decide what the options are for his treatment. Parkinson's disease is a neurodegenerative disorder of the extrapyramidal system associated with the disruption of neurotransmission in the striatum. The striatum is one of the principal components of the basal ganglia, a group of nuclei that have a variety of functions but are best known for their role in facilitating voluntary movement. Parkinson's disease is characterized by dyskinesias and akinesia, as shown in the figure. Proper function of the striatum requires a balance between the neurotransmitters dopamine and acetylcholine. The imbalance between dopamine and acetylcholine results from the degeneration of the neurons that supply dopamine to the striatum. Without adequate dopamine, acetylcholine causes excessive stimulation of neurons that release gamma-aminobutyric acid, or GABA. Overactivity of GABA neurons contributes to the motor symptoms of Parkinson's disease. Parkinson's disease is very common and affects more than 1 million Americans. You will care for Parkinson's disease patients in your practice. I have diagnosed them and begun treatment, but then have referred them to a neurologist. Parkinson's disease is second only to Alzheimer's disease as the most common degenerative disease of the neurons. Symptoms generally appear during middle age and then progress. There is no cure, but drug therapy can maintain functional mobility for years. Therapeutic goals for treatment is to improve the patient's ability to carry out the activities of daily living. Drug selection and dosages are determined by the extent to which Parkinson's disease interferes with work, dressing, eating, bathing, and other activities of daily living. Initial treatment options include levodopa, dopamine agonist, or dopamine replacement, or a monoamine oxidase type B, or MAOB inhibitor that would be used if the symptoms were mild. If improving motor function is the primary objective, then levodopa is preferred. However, if drug-induced dyskinesias are a primary concern, such as those that develop from long-term use of levodopa, then a dopamine agonist would be preferred. After a period of good control with levodopa, motor fluctuations, the wearing off and wearing on phenomenon, and dyskinesias develop in almost all patients within 10 years. Off times can be categorized as on-off or weaning off, and they basically mean the same thing. They are the on-off phenomenon in Parkinson's disease refers to a switch between mobility and immobility. Drug-induced dyskinesias are involuntary movements. It often involves hyperkinetic movements, including chorea, dystonia, and athetosis, and oftentimes can be reduced with dopamine agonists, the COMT inhibitors, and the MAOB inhibitors. Levodopa is given only in combination. Adding carbidopa or carbidopa entacapone decreases the amount of decarboxylation in the periphery so that more of the drug can enter the central nervous system. At the beginning of treatment, about 75% of patients experience a 50% reduction in symptom severity. Levodopa is so effective, in fact, that a diagnosis of Parkinson's disease should be questioned if the patient fails to respond. Several months of treatment are needed for the full therapeutic response. Levodopa is highly effective, but benefits diminish over time. Symptoms are well controlled for the first 2 years, but return to pre-treatment state at the end of 5 years. As the disease advances, other medications will be added. This may require reduction in the levodopa dose to minimize dyskinesias. It is administered orally and is rapidly absorbed from the small intestine. Food delays absorption, especially high-protein foods that compete with levodopa for intestinal absorption and for transport across blood-brain barrier. Because of this competition, high-protein foods reduce its therapeutic effects. Levodopa must be converted to dopamine, its active form, in the brain. Gradual loss or wearing off that develops near the end of the dosing interval indicates that the drug levels have declined to a subtherapeutic value. Wearing off can be minimized in 3 ways: shortening the dosing interval, so giving it more frequently, giving a drug that prolongs levodopa's plasma half-life, such as entacapone, or giving a direct-acting dopamine agonist. Activation of dopamine receptors in the chemoreceptor trigger zone of the medulla can cause nausea and vomiting as an adverse effect. To prevent this, low initial doses or administration with food can reduce the nausea and vomiting. But if you give it with food, it also reduces the therapeutic effects by decreasing levodopa absorption. Another option is to give additional carbidopa without levodopa, and that can help reduce nausea and vomiting. The reason that carbidopa helps is unknown. Postural hypotension is another adverse effect. Reduction of postural hypotension can be accomplished by increasing the intake of salt and water, using the lowest dose necessary, and limiting the use of alpha antagonists. Central nervous system effects can include psychosis, visual hallucinations, vivid dreams or nightmares, or paranoid ideation. It's caused by activation of the dopamine receptors. Symptoms can be reduced by lowering the levodopa dosage, but this will reduce the beneficial effects as well. There are other central nervous system effects that are listed here. The most notable are the behavioral changes associated with promiscuity, gambling, binge eating, and alcohol abuse. So patients and their caregivers must know about this potential. Levodopa is given to alleviate movement disorders, but it actually can cause movement disorders in many patients. Some dyskinesias are just annoying, others can be disabling. They develop just before or soon after optimal levodopa dosage has been achieved. Dyskinesias can be managed in 3 ways: reducing the dosage of levodopa, adding amantadine or a dopamine agonist, and then surgery and electrical stimulation. There are other adverse effects such as darkening sweat and urine, and a very interesting one where it activates malignant melanoma, so it's important to perform a careful skin assessment of patients who are prescribed levodopa. Some drug interactions with levodopa. First-generation antipsychotic drugs block receptors for dopamine in the striatum and decrease therapeutic effects of levodopa. MAOI inhibitors, levodopa can cause a hypertensive crisis if administered to an individual taking a non-selective MAO inhibitor. And then excessive stimulation of cholinergic receptors contributes to the dyskinesias of Parkinson's disease. So if you're given an anticholinergic drug that blocks these receptors, the drug can enhance the responses to levodopa. Dopamine agonists are also first-line drugs for Parkinson's disease. They cause a direct activation of dopamine receptors in the striatum. Dopamine agonists, in comparison with levodopa, are less effective than levodopa, but they're not dependent on enzymatic conversion to be active. They do not compete with dietary proteins. There's a lower incidence of response failure, and they're less likely to cause dyskinesias. There's two types of dopamine agonists. We will be covering the non-ergos, but not the ergos, as we would not be prescribing them in primary care and they are seldom used. So I doubt your patients would be on these. Pramipexole can be used as monotherapy in early Parkinson's disease and with levodopa in advancing Parkinson's disease. It can be used first line, especially in younger patients less than 50 years of age. It can be added to levodopa to reduce off time, improve symptoms, or manage dyskinesias due to levodopa. Its maximal benefits take several weeks to develop. The adverse effects are similar to levodopa, carbidopa. With monotherapy, there can be nausea, dizziness, daytime somnolence, insomnia. Just go on with it. There is a higher risk of hallucinations and sleepiness than with levodopa and carbidopa. When used in combination, the adverse effects include orthostatic hypotension, dyskinesias, and increase in hallucinations. It may impair impulse control, so warn the patient. Management includes dose reduction or discontinuation if this appears. Ropinirole is Recrip. Both drugs, pramipexole and ropinirole, share the same indications: Parkinson's disease and restless leg syndrome. Ropinirole can be used as monotherapy for early Parkinson's disease and as an adjunct to levodopa for advanced Parkinson's disease. The most common effects are nausea, dizziness, somnolence, and hallucinations. Rarely, sleep attacks will occur where the patient will experience uncontrollable episodes of falling asleep during the daytime. When ropinirole is combined with levodopa, the most important side effects are dyskinesias, hallucinations, and postural hypotension. Like pramipexole, compulsive gambling, shopping, eating, and hypersexuality may occur. Rotigotine is also very similar to pramipexole and ropinirole, except that it is transdermal. So I'm not going to go over the rest. COMT inhibitors inhibit the metabolism of levodopa in the periphery. They are used as an adjunct to levodopa, carbidopa, and is not for monotherapy. They have no direct therapeutic effects of their own. They prolong the action of levodopa, so are added to levodopa to reduce off time. Addition of COMT inhibitors can increase levodopa-carbidopa side effects, including dyskinesias. Thus, the levodopa dose may need to be decreased. There are two COMT inhibitors available. The first is edacapone, which is safer and more effective. It can cause orange urine. There's a combo product with levodopa-carbidopa plus edacapone, which is called Stalevo. That's the brand name. It decreases the pill burden and may cost less than separate prescriptions for etiquepone plus levodopa-carbidopa. The second COMT inhibitor is tolcapone. It requires liver function test monitoring. COMT inhibitors also cause gastrointestinal side effects. MAOB inhibitors are considered first-line drugs for the treatment of Parkinson's disease also. Salicyline and rasagiline can be used as monotherapy or used with levodopa. They only have a modest improvement in motor function. They act by selectively and irreversibly inhibiting MAOB. They suppress the destruction of dopamine that's derived from levodopa and prolong the effects of levodopa. The benefits, however, decline dramatically within 12 to 24 months. These drugs may cause hallucinations or orthostasis, especially salicyline plus levodopa. Other side effects include nausea and insomnia. Salicyline can be particularly activating, so give in the morning and or at noon. Salicyline and rasagiline may also cause dry mouth, constipation, and vivid dreams. Many potential drug interactions are due to the MAO inhibition. So there are antidepressants, which are actually commonly combined, tramadol, meperidine, methadone, dextromethorphan, amphetamines, and other MAO inhibitors. Just a couple of more drugs yet to review for the treatment of Parkinson's disease. Amantadine was originally developed as an antiviral agent. It was later found to be effective for Parkinson's disease. It has mild to modest immediate benefit for most symptoms. Its effects are much less profound than with levodopa or the dopamine agonists. It is not considered a first-line agent, but can be used to target tremor or added to levodopa and later disease for dyskinesias. I wanted to share a strange adverse effect called livedo reticularis, a condition characterized by mottled discoloration of the skin. One last drug to discuss, benztropine. It is used to target tremor, especially in patients less than 60 years of age. It is less effective than levodopa or the dopamine agonists, but better tolerated. It should be avoided in the elderly who are intolerant of CNS side effects, the sedation, confusion, delusions, and hallucinations. It also has anticholinergic effects of dry mouth, urinary retention, and constipation. Remember Bob? What would you initially prescribe for Bob, and what is your rationale? There are several different options here. Personally, I would prescribe the levodopa-carbidopa, as the MAOBs have minimal effect on symptoms. You could argue that an MAOB would delay onset of dyskinesia from levodopa, but I don't see this being done that much. You could also add a dopamine agonist. But one of the reasons I like levodopa is that the improvements of symptoms with levodopa is diagnostic. Okay, so Bob's disease has progressed, and he complains that he tends to slow down an hour or two before he's to take his next dose. The patient is exhibiting which of these? He's actually, A and C are the same thing, so he's showing signs of both of them. So what might you prescribe now? So you could add anything now. You could add a dopamine agonist, the COMT inhibitors, or an MAOB inhibitor. Thank you for your time and attention. I hope you continue to have a great day.